Well, thank you, and good afternoon. My name is Clifford Ko. As Ian said, I'm a surgeon in Los Angeles. I work at UCLA. I'm a colon surgeon. I mostly take care of patients with colorectal cancer. My other job is in Chicago, and it's at the American College of Surgeons. And at that job, I work with quality, the quality division, and I help and participate in a number of programs that try to evaluate and try to improve and try to sustain the quality of patient care. And so I think that everyone in the room can, hopefully that'll resonate with them, because regardless of what an individual does, whether it's the surgeon or anesthesiologist or nursing or pharmacy or the lead of the hospital or anyone, we're all trying to do the same thing, is try to really improve the care for our patients. And I was very happy when Ian had asked to talk about, there's a lot of different aspects to talk about in quality, but when he asked to talk about teamwork and communication, it really made me happy, because I think that teamwork and communication is the foundation for achieving quality, achieving sustainable, reliable quality. And a lot of times when folks start working on quality, they think it's going to be something technical. It's how the surgeon threw the stitch, or how much opiate we gave this one patient, and how much we decided to do X, Y, or Z. And those are not, it's not that they're not important, but the things that really make it sustainable and reliable and we don't have to reinvent the wheel are things when we communicate. And we learn a lot faster, and we achieve a lot more as a team rather than an individual. And there are examples, I think I have some in here, where there are things that surgeons have just kind of said, I'm the surgeon, listen to me, just follow, just get on my back and I'll take us to the promised land. And it usually doesn't work. It usually is not sustainable. It usually is not the best answer. And so again, when he asked to talk about, asked me to address teamwork and communication, I was thrilled. And so I'm going to talk to you about some lessons that we've learned, and in terms of teamwork and communication and how to foster it. Because even though we say teamwork and communication, it just slips off our tongue very easily, it's not always it's not always so easy to achieve. In fact, sometimes it's very hard to achieve, because there's often barriers. So let me get started. Excuse me. I work at the American College of Surgeons. It's the professional organization for surgeons in the United States and Canada. There are 80,000 members in this organization, and this is our mission statement. So if you ever come to Chicago, come visit. It's right downtown Chicago. On the 28th floor is our boardroom, where we have our board meetings, and this is what's up there on the wall for everyone to see. That the college is dedicated to improving the care of the surgical patient. At the end of the day, this is for the patient, and to safeguarding standards of care. And standards is a really key word, which I'll show you later in the talk, because when it's a standard, we understand it, we expect it, we know that it'll happen, and otherwise it's chaos. Standards of care in an optimal and ethical practice environment. Those are very purposely chosen words when the college did that. And that is the mission. So this is a slightly complex slide, but this shows you some of the programs that the college has. And from these programs are the observations and lessons that I want to share with you. But as an example, let me start here. In 1922 was the first cancer registry that was done in the United States. It was a bone cancer registry that they started to collect data on patients with bone cancer. Now it's a program with 1,500 hospitals in the United States that participate in this. They bring data together in the cancer registry, and they also participate in an accreditation program where there are standards, how they take care of patients, how they discuss patients who need chemotherapy and surgery and radiation therapy, how they discuss cure versus palliative care, how they discuss after surgical care, and how they go on for more treatment. So this is a program that ensures that these things are occurring at these 1,500 hospitals. Most of the cancers in the United States, 80% of the cancers, are treated in these 1,500 hospitals, and this is what that program is, the Commission on Cancer. A program similar to that is this. It's the trauma program, and TQIP stands for the Trauma Quality Improvement Program. And if you've heard of the level 1 or level 2, 3, 4 trauma centers in the United States and how they get designated as that and how they get accredited for that, that's this program here. It's the trauma program. And similar to the cancer program, there are standards. There's a data registry, so they know how they're doing, and excuse me, they have an on-site audit every 3 years to ensure that that's going well. There's a bariatric program, which 10 years ago in the United States, the mortality rates and the complication rates of bariatric surgery were extremely high, and our government in the United States said that, all right, we're going to stop this. For you to do bariatric surgery at your facility has to be audited and has to be accredited to do it. And so we developed an accreditation program, which is now called MBSA-QIP. It doesn't matter what that stands for, but it's MBSA-QIP, and there are about 800 hospitals now in the United States that are accredited for that. These 3 programs, in addition to, there's a development of a pediatric surgery program and a geriatric program. These are all based on the same kind of strategy, that we need to have data, we need to have really accurate data to know how we're doing, but we also need to have standards and protocols in place. So standardization, we need to have it be multidisciplinary of different factions of who are caring for the patients and putting that all together. The other program that we have that is somewhat different is called ACS NSQIP. NSQIP stands for the National Surgical Quality Improvement Program. This is a program that collects data on all types of surgery, everything except cardiac surgery. And it feeds data back so that hospitals and surgeons and surgical teams know how they're doing. It largely uses outcomes, and so mortality and complications such as infection, SSI, surgical site infection, urinary tract infection, pneumonia, sepsis, things that we don't want to see in our patients, but happen in our patients, and it feeds back how we're doing. So at my hospital, I know what our rates are, and they're risk adjusted, so it takes into account the acuity of the patients that have come to our hospital. And then it benchmarks it, so I can see how UCLA does, where I work, compared to the other 600 hospitals there. And are we one of the better hospitals? Are we one of the worst hospitals? Are we getting better? You know, if I get a report 6 months ago versus now, are we improving or not? And it gives us fodder so that we can improve, so that we know if we have to improve, or lets us know, all right, we're at the 80th percentile, we can get a little better. There are hospitals that are better than us. What can we learn from them, and how do we do improvement? And again, as I started off saying, that the key to improvement is going to be teamwork and communication. At least that's what we've seen across all of these different programs. This again iterates the need for data, but the need for infrastructure like staffing, appropriate committees and equipment, and then standardization of how we do things, but I'll talk more on that later. The verification piece is the every 3-year visit when hospitals are visited to make sure that their infrastructure is in place, that the protocols are in place and they're following them. One of the things that we know that when we visit a hospital, if we ask the president or the executive officer of the hospital, how do you do quality? How do you ensure that you have quality in your colorectal surgery that you perform? And then we'll ask that same question of the head, the director of surgery. And then we'll ask that question of the director of nursing and anesthesia. And then we'll ask the surgeons who operate every day and who are kind of in the trenches doing the work. And if we get the same answer from all 3 of those levels, then we know that place is going to be pretty good. There's going to be communication amongst them. They know how they're doing things. They have some kind of standardization. They have some kind of teamwork that's going to be available to do those things. That place will be pretty good. I dare say that when we visit hospitals, the minority of hospitals can answer those in the same way. But that's something absolutely that we should all be trying to achieve. If we have those, this is a study that was done for the trauma centers, that When we have infrastructure and protocols and it's data-driven and it's verified every so often that these things are happening in that hospital, when we look at these types of hospitals where there can be a reduction in untoward events. This is a study that was in the New England Journal that shows that there's a 25% reduction in mortality in what is one of the largest predictors of, or one of the most common reasons for mortality in an age group of under 55. In the NISQIP program, this is the one of the databases that we've seen that if you feed data back in a believable way to the people who are giving care to these patients, we can see that the percent of institutions that decrease statistically their complication rates is 82%, and 66% decrease their mortality rate in a statistical way. So feeding back data is very important. That is the first step, but there's clearly more than that. If we look at feeding data back, and the prior slide was over 2 or 3 years, this is looking over 8 years. The program has been in existence for 10 years, and so we did it for the first 8 years of the program. We see that, by and large, a lot of these complications improve. What's really interesting, and this is a group for looking at harm, not all things are equally easy to fix, and I'll get into that a little later. Some things are just more complex because they're multifactorial, and you have to figure out what the issues are, and some include just, a smaller team, some include a larger team, but you'll see that over this 8-year period, some things are easier to fix, like urinary tract infection. So we know that hospitals that have a urinary tract infection problem, their rates are too high. They can be fixed probably a lot easier than things like SSI, which is harder, or mortality, which is one of the hardest things to fix. So a lot of this is because of the topic area. A lot of it is because of the people who are needed to be on the team and the communication that's needed. This slide shows that if you take the hospitals that need to have improvement and the hospitals that are doing better than expected, and this is the first year of the study in 2005. These are the bad outliers and these are the good outliers, and these are for complications. We can see that the next year, most of the bad hospitals got better, which is what you would expect. If if a hospital is doing worse than expected, if you just give them time, give them data back, their opportunity is to get better, and most of them do get better. But what's really interesting is that if we look at 2 years out, so everything in green in 2007 is improvement, and then we see that most every hospital got better. The bad ones got better, but also the good ones got better. And this was done, almost 10 years ago, this study. But since then, we've seen that even if a hospital is doing really well on their results, on their benchmarking reports, there's always an opportunity to get better. No hospital is great at everything. No service is great at everything. No surgeon are there surgeons in the room? No surgeon is great at everything. So this was a key lesson for us because we found out that we can always improve no matter where we are on the curve, even the really good hospitals. And this was seen for both complications as well as mortality, where these hospitals got better the first year, but if you look at all the hospitals got better over 2 years, both the hospitals that were not performing well, but also the hospitals that were performing well got better. So no matter where we are, no matter how great we think we are, we can always get better. So I'm going to go through some observations and some lessons that we've seen from these almost 3,000 hospitals across trauma, cancer, bariatric, endocrine, urology, orthopedics, what we've seen. So here's the first thing. Some hospitals took longer. As you can see from that last slide, some took 1 year, some took 2 years, some took more than that. But really the key part of this was standardizing and using evidence-based practice. So as much as we can, when we talk about evidence-based practice, there's clearly evidence from the literature, but not always do we have evidence in the literature. We take it where we can get it, and where people have done studies, we should absolutely grab hold of that and respect it. However, for not everything that we do is there evidence. Not everything that we do is there a randomized controlled trial with level 1 evidence that's going to tell us what to do. And in those cases, we need to turn to our experts. We need to turn to our clinical experts who've done this hundreds and hundreds of times, or the head of nursing in the ICU who has seen this whole setup, hundreds and hundreds of times, or, the anesthesiologist who has taken care of this patient, this type of patient who's sick and coming in through the emergency department and is, having all these acuity, difficult things, who's done this hundreds and hundreds of times. There might not be a study on these things, but, experience absolutely counts. And so that is the second piece of evidence-based practice. The third piece is that we have to marry all these things with the patient. A lot of times we have to take care of the patient's values, the patient's preferences, and we have to know those types of things. I can tell you at our hospital in the States, if I ask one of our trainees, what does this patient want? What is this, what would they rather have, quality of life or quantity of life? Would they have quantity and low quality, or high quality and low quantity? You know what I mean. And a lot of times our residents don't know. Sometimes our faculty, my colleagues don't know, because we don't necessarily always kind of spend enough time to talk to them about those things. But it's clearly important. Increasingly, we're all getting measured on patient's experience, patient satisfaction, because at the end of the day, we're doing this for the patient. And clearly, if somebody wants to live longer, with quantity versus quality, that's a different strategy. And if somebody wants to live a higher quality of life but not necessarily have that quantity. So these are very important things, and we have to marry all these things together to get evidence-based practice. Once we decide how to do this within a practice, the next part is standardizing. And I can tell you that, so I'm a colon surgeon. There are 5 other colon surgeons where I work, and we decided that somebody suggested to us very strongly, our bosses did, said, you guys got to standardize. Cliff, you have your instrument trays this big, and you have these specific things you want in the operating room and how you take care of the patients afterwards. And then everyone else has a different tray that they use in the operating room. They have a different routine. They do different things post-op. We all did different things pre-op, and it was driving the hospital crazy. It was driving the nurses crazy. It was driving anesthesia crazy. It was driving other surgeons crazy. It was driving the staff, the house staff, the trainees crazy, because this is a Dr. Ko patient. We have to do this. And this is a Dr. Smith patient. We have to not do that. We have to do this. And it brought about a lot of errors. It brought about errors because we did it this way. We didn't. It was chaos. So we tried to get all of us, which are these, into doing things the same way. And we standardize how we do things, how we evaluate the patient pre-op, what we do in the operating room. Our instrument trays are now all the same. We all have a closing tray. We all give the same perioperative antibiotics. We change our gloves all the same way. And then post-operatively, we do things. We standardized it. It took the better part of 2 years to do this. And, we're 5 surgeons. We're all trained to do colon surgery. We had such great disagreements. We were yelling and screaming, and we even tried to get people to come, and we have pizza, but nobody ate it. They're throwing it at each other. We really had a hard time, but as soon as we finally standardized, great things happened. And I'm not promising that if you standardize, great things will happen, but we were so dysfunctional beforehand that we couldn't have any place to go except up. So one of the things that we did was that because one of the reasons we needed to standardize was that our readmission rate was too high. What we would, so we would discharge the patient and the patients would come back, and our rate was 18%, and it should be closer to 10%. And so we spent a lot of time on how we're going to discharge the patient, what kind of information, how they call back to us, do we call them, how do we work the whole system so that it's best for our patients. And so basically within a quarter, we went from 18% to 10%, which is great. So now we're average. We went from terrible to average. But it was from standardization. It was from each of us knowing, every part of the team knowing what was going on. And so this is part of the teamwork and part of the communication that everyone knew what was going on. In your hospitals, I'm pretty sure that you're doing some protocols similar for this, which is an ERAS, Enhanced Recovery After Surgery. It's a great content topic area for teams to get together and rally around. It involves surgery, it involves anesthesia, it involves nursing. Through the continuity of care, it involves pre-op care where there's patient education in the clinic prior to surgery where you tell the patient what's going to go on for the next 14, 30 days. And it involves pre, intra, and post-op. The enhanced recovery after surgery is a great topic area, and it results in oftentimes improved resource use, so it's decreased resource use, decreased length of stay, standardization, and then the great thing about it also is that the topic areas, the protocols and the processes are very evidence-based. And so this is a great area for people to work on, and this is just a systematic review that I put up there that shows that it works. It decreases length of stay. Other studies have shown it decreases resource use in terms of instruments. It makes the patients happier, and complications and harm go down. So this is a great topic area, enhanced recovery after surgery, ERAS. Now, the second observation after standardization is this, because people tell you to standardize all the time. So if you read any book on quality, standardization. If you see variation, that's bad. You want standardization, you want to decrease variability, you want to increase reliability, all those types of things. You hear it over and over and over again. But what they don't tell you is this, is that while standardization is essential, something more was needed. And if you look at this line here, there's standardization, standardization, and standardization. You know, we all use the same antibiotic. We all scrub the same way. We all use the same prep. We all gave the same mechanical prep. All that standardization. But there are things that happen in between the times of standardization. And this is going to be key, and I think this is great for this group to hear because this is knowledge that is really important to have. So in between the standardization, something is happening. There is something happening there. And when we looked at these hundreds of hospitals, thousands of hospitals, we kept on asking, what's happening between these times? How did you get from, this level of standardization to this level? What is going on in here, or what's going on here? And what they said is that we tried something new. We changed something. We innovated something. And so this is the key point that, a lot of those quality manuals, those quality books do not tell us, is the innovation piece. Is if you look at this here, this line, you don't want to be this line because there's no standardization, and there's just kind of this sine wave of going up and down, up and down. 1 month we're good, 1 month we're bad. 1 month we're good, and it's just kind of going all over the place. You definitely need standardization, but you also need the innovation between that. If you look at this line here, if you look at what, this hospital is basically doing nothing, and this one is very purposefully doing standardization and kind of innovation in between times. This delta, this difference from here to here is the difference, and that's what continuous quality improvement really is. It is really continuous. To think that we're going to just work on something, fix it, and then go off, do something else, and have that same thing continue to be good, sustainably good, doesn't happen. Doesn't happen. You always have to be kind of looking at it, maintaining it, sustaining it by reviewing it, and it's a real continuous journey. It's a journey, and so that's what this piece is. It's this piece in here in addition to the standardization. Standardization is hard enough. You need to have some stuff in between. I will here. So. The question we asked these folks then, when we had these hospitals that we understood that there has to be innovation or change between the standardization, then the question we asked is, how did you know when you had to stop standardizing and change? And so how did you know in these areas here, what told you that at this point you had to stop standardizing and change something, stop standardizing and change something? And so the hospital said this: we did it based on data. The data told us. The data told us that we're not, things were slipping. Things were not as good. The data told us that we needed to do something different. And so if you look at this is a typical graph that we give back in our programs. We call it a caterpillar graph. And this line of 1 is basically average. And these hospitals are doing better than average. Their harm rate or their complication rate is below average. So they're doing very well. But when this hospital starts to see that this thing slips and they start to get worse, that triggered to them, we need to do something different. Our standard way of doing things, something is going off. We need to rethink about how we're doing things. We need to reinvent something. We need to change something. And that's what happened. That's how they knew when they had to stop doing the things the way they were doing it and change something. So I met somebody earlier from Pennsylvania who talked about hockey, and I had this in between. But this is ice hockey. And this player, his name is Wayne Gretzky. He's one of the best players. And there's a famous quote about Wayne Gretzky, is that, why was he so great? And he says, I skate to where the puck is going to be, not where it's been. And it's really kind of funny in the United States, like a lot of business people quote, they don't even know what hockey is, but they quote this because they think they're very visionary in what they're doing. The better quote for quality improvement, I mean, this is good for quality improvement, but the better quote for quality improvement is this, because he always said this: you miss 100% of the shots you don't take. And basically he's saying that, if you don't try, you don't succeed. And if you look at a typical hockey game, the one who shoots more, has more shots on goal, it usually wins the game. And this is another lesson that we learned from this in terms of the innovation piece, is that when data told them something was amiss, something needed to be done, achieving providers took more shots. These hospitals, you could see that they started to try things. And what's really important here is the team aspect of trying things. Is it the surgeon saying, like, okay, I know what the answer is, let's do this? What really happened was that the team got together and together figured it out. Because a lot of times the surgeon might say something and this happened in our experience, is that we'd say, oh, the fix is this. And the nurses would say, no, that's not feasible. That would never work because of X, Y, or Z. And so it needs to be a multidisciplinary team aspect of trying new things. So teams, when we visited these hospitals and figured out how they innovated, how they changed, they usually employed new ways to learn what they didn't know how to do. So if they knew what to do, they would be doing it. They're innovating in areas that they don't know how to do. So they're kind of it's in the discovery phase. They don't know what to do, so they're trying. They often required accelerating the failure cycle, not avoiding failure. So one of the issues in trying new things is that do we try new things and we fail? Do we try new things and not fail? Obviously, we try to do things and not fail. But if you look at innovators, invention people, Steve Jobs, people like that, they fail a lot. They just get back up on their feet and try again, and then they fail quickly, and they fail strategically, which I'll get to. But they fail quickly. They go through, all right, let's try this. There's 10 different options. Let's try option 1. Doesn't work. Option 2 doesn't work. Option 3, and they fail, and they go through this failure. As we standardize and we have to innovate and we have to change things, we often will fail, and we can't expect to hit a home run or score a goal every single time. We have to understand that failure is part of it, and they fail strategically. The two things about failing strategically that we see, that we noted from these, is that they fail in the corner. So you don't want to fail on a podium in the spotlight. You don't want to fail when you're on Broadway. So that's number one. You want to fail in the corner in a small piece, and you want to fail cheaply. So you want to fail not having the CEO of the hospital who gave you thousands and thousands of dollars to try something. You want to start small, and if you're going to fail, fine. You just failed small. Move on to the next thing. And so failing strategically is really important. Failing is also a great learning experience. And you kind of, you have to live like the hurt didn't it parent. And this is kind of like, I have a neighbor who has a little boy. He's 3 years old, and the boy doesn't want to ever tie his shoes. And mom always comes out and ties the kid's shoes. But if it weren't for mom, kid's shoes would never be tied. So one day I was out there with the dad and the little boy, and as usual, the little boy's shoes were untied, and the boy starts running and trips and falls, skins his knee, starts crying. And the dad goes up to his boy and says, hurt, didn't it? And so teaching the boy that he needs to tie his shoes. And so sometimes we have to learn those types of lessons through failure. And that's one of the key things, is that you want to keep it small, you want to keep it cheap when you do fail, but you have to learn those lessons from it. What's probably key for everyone in this room is this one, is that smart people haven't had a lot of the opportunity to fail because they haven't. They're smart. They don't go down the route of failure. And so a lot of times smart people are not really good at failing. at not picking the right choice, at not doing the right thing. But if we're going to innovate and if we're going to change and we're going to go kind of in this frontier of discovery and not know what to do, we have to be more comfortable with failing. And so they haven't had the opportunities to fail and consider those alternatives. So when they do fail, a lot of smart people are not good at failing because then they just point the finger at somebody else. That's not good teamwork. When somebody fails, they have to take, a lot of times, take ownership. If you've been in, and I love going to M&M and seeing surgeons stand up and say, you know what, this was my patient, I screwed up. I was deciding whether I should operate in this hole or, operate in that hole. I chose this one, and it bled, and we had to transfuse, 17 units of blood. I screwed up. I shouldn't have done that. When surgeons or when anyone takes ownership of that, that's great. That is great culture, and that'll lead to much closer and better teamwork. Because if that person doesn't say that, then nobody else will want to admit anything, and there won't be that great communication. So accepting the notion that we always don't know is really, really, really important as part of the team. So fail early and off Broadway, learn from failures, and fail cheap. The third observation is this one. And this is also very important for a team because of the notion of more than one way to do things. And so consider and embrace equifinality. And equifinality means basically there's more than one way to do things. And there can be more than one solution, and we often need to discover what the solution is. And so the typical thing that people say, there's more than one way to get to Rome. And we did a study where we tried to fix surgical site infection, which is one of the biggest harms in the United States that, as a whole country, we're trying to address. It is the #1 complication across all types of surgery, surgical site infection. And we had a number of hospitals that got together. We had 8 hospitals, and they all had higher than expected surgical site infection rates. And we worked on it all together, and this was a 2-year project. It was like $1 million. It was very high cost because we had a lot of data collection and we had a lot of experts on quality improvement. And they were good hospitals. It was, I don't know if you've heard it, the Mayo Clinic and the Cleveland Clinic and Stanford Hospital. These are very, very prestigious, well-known hospitals in the United States. They all participated in it. And at the beginning of this study, there was this notion from the leader of this study who said that, you know what, we're going to find the it factor. We're going to find the factor that is going to fix everyone's surgical site infection. And for us, the surgeons involved in the study, we thought, well, it's probably, we've never found the it factor. And we've been doing surgeries for centuries, and nobody has ever found the it factor. What does this person think that they're going to study this for a year or two and then find the it factor all of a sudden? But he was very confident in this, and we used this process called Six Sigma, which you may or may not know, because it's very analytic, collect a lot of data, do a lot of analyses. And at the end of the day, what they found was that for surgical site infection of this type of procedure, there were over 200 factors that could potentially play into having a surgical site infection. And what we found at the end of the day is that after 2 years, all the hospitals got better, but all the hospitals had to fix something different. The Mayo Clinic fixed something different than the Cleveland Clinic, fixed something than Stanford, than Northwestern, than other hospitals. They all had to fix something different. They all had to identify what it was, and they had to fix something different. So a lot of times when we say, oh, just do this, it may work, but it might not. And so the idea of equifinality, of more than one way to do something, is absolutely in place, especially when things are very seemingly complex. Surgical site infection is like that. If you think about readmission, what are the reasons why patients get readmitted? There could be a lot of, the surgery could have gone, there are complications, an infection, a urinary tract infection, a pneumonia. It could be that, they fell over because we gave them too much, they're hypertensive, and they have a head bleed, and they came back. There could be literally hundreds and thousands of reasons they came back. So the fix is going to be very different. And so it's very important that we understand this concept of equifinality. lots of solutions to one outcome. So the fourth thing is this, and this was the topic of this of the whole day, the whole workshop, is this: communication and teamwork. And this is all part of culture, and whenever we say culture, it's a lot of these concepts all together, is routinely associated with sustained quality and safety improvement. And so what is culture? So this is one of the definitions from our sociologists. If you look at that, it's a set of shared mental assumptions that guide interpretation and action in organizations, defining appropriate behavior for various situations. It doesn't mean very much. It's too complex for me to understand. But, this is a better way of saying it. The way things get done around here, that's the culture. That's the piece. And clearly, if you visit different places, you see different cultures. And it's not just hospitals. It's, if you go into a store or, a restaurant, there's a different culture. And you can see how those things are very inherent into that organization. The most important thing to think about culture is this: it is the most difficult attribute to change. It can outlast the products that an organization produces, the services, the founders, the leadership, and all other physical attributes of the organization. We have, at the American College of Surgeons, where I work in Chicago, we have 350, 400 staff, and the culture is not all that great. We have people coming in to help us coach, and most everyone says it takes at least 5 years to really make a dent in changing culture. But the key thing is that from quality improvement, there is a real great reason to move forward with culture, and the things like teamwork and communication will more readily improve culture than almost anything else. So that's what we have on our side. Now, when we think about culture and we think about evidence, which I talked about earlier, and when we're trying to achieve quality improvement, we should know things that are kind of in our favor or maybe not in our favor. And so when we want to implement something and we want to change things, we can have we should know what to expect. We should know the context and we should know what to expect. And so if you look at evidence as being strong or weak, the evidence of what we're trying to do, and culture in the place, in the facility, or in the pocket, or on the service, or in the unit as being strong or weak, we can have a good idea of how things are going to be implemented, the success or not of these things. So the ideal situation is if we're trying to implement strong evidence in a culture that is very good. It's almost a no-brainer. We could say, do this, it's good culture, it'll get done. But these other three boxes are areas that are probably more common because the evidence can be weak or the culture might also be weak. And so it's a little difficult in these areas, and you have to work on different aspects if you look at these two things, evidence and culture. It's really important to know these things as you're trying to achieve quality improvement. And again, the communication piece of this will be very important. So, communication and teamwork will likely improve as quality and safety is also improved. And this is a study that we did with one of our hospitals that had a high infection rate, and we tried to evaluate them and try to improve it. And one of the strategies was that we were trying to improve their culture. We were trying to improve their communication and their teamwork and their engagement and their empowerment and things like that. And so we tried to study them from beginning to end. At the beginning, we measured their communication and teamwork with something called the SAQ, the Safety Attitudes Questionnaire. And it showed that this hospital, this unit, had the third worst culture, the third worst communication and teamwork in the whole hospital. They filled out this survey and they said, would you have your family come to this hospital? No. Do you trust your people who you work with? No. Do you even talk to them if you don't have? No. All these things, it was really negative. And they were one of the worst units, pockets in this hospital. Well, the leadership, because the surgical site infection was so high, they had to do this. It was a mandate from the top, and so they started working on this. And they were very lucky to have these two leaders, an anesthesiologist, three leaders, a nurse, an anesthesiologist, and a surgeon, together And they really believed that they could change things. They got together, they had these meetings at first every month, but then it was set to every 2 weeks. They worked on things that the whole team came up with. The team of surgeons, nurses, and anesthesiologists and pharmacists and whatnot. And they started to see gains. They started to get better. They started to put a protocol in place, and it worked. The nurses started doing things in the operating room. It started standardized. They started to do things together. Their timeouts and briefings were much better. And by the end of the first year of the project, their surgical site infection rate went down, but also their culture and their communication and their teamwork got better, according to this same survey. Would you send your family here? Do you trust who you work with? Do you believe that they're on it? All those types of things. And it got better. By the 2-year time point, they were the best unit in the hospital, because they kept on working on these things together as a unit. They kept on doing it. It wasn't the surgeon leading it, follow me. It was all of them together. They kept up their every other week meetings. It soon, as we were following this from the American College of Surgeons, very early on in their meetings, some people came, some didn't. They served food so more people would come. After a year's point, these meetings were standing room only, because people wanted to come and participate, and because they felt like they were being listened to. They had the engagement. They felt empowered to put forth suggestions. Oh, let's try this. Let's try this, and it really improved. And so their culture, their teamwork, and their communication became the best in this hospital in the span of 2 years, from the 4th worst. I'm not going to talk out of school, because this is published work. This is Johns Hopkins University, which is one of our best hospitals and universities in the United States. And so it was very important for us to see this journey that this unit took. What is also really important is that the culture improvement was noticeable to other places. And so this kind of gave us this notion that a hospital might have a culture, but there are also pockets of cultures within the hospital. So this was the colon surgeons, but the urologists who shared the floor with them didn't have the same culture. They didn't do the same work. But it was very noticeable to the urologists that said, "What are those colon surgeons doing? We want to do what they're doing. Who's helping them lead these meetings? Who's doing this? What kind of data are they using? How are they feeding it back? How are they getting, people to come up with new things? How are they implementing these things? Why is everyone talking about the colon surgeons and not the urologists?" And so it was infectious. And soon the urologists started doing this, and soon the liver surgeons started doing this, and then the pancreas surgeons. And so it was infectious by this one group starting it off first. And so that was a great lesson for us, because first of all, it can be achieved, and it is infectious. This is typically what is found, and this is data from the hospital I work in, but we've seen this at other places, and you've probably seen this before. So when we go visit a hospital, we hear, oh, we have, great or, pretty good cultured teamwork and leadership, and usually it's the leaders of the hospital that tells us this. And so we sometimes do these surveys with hospitals. Do you think surgeons and anesthesiologists work together as a well-coordinated team? And so we ask people in the operating room, and we ask surgeons, and we ask nurses, and we ask the anesthesiologists. We ask a whole bunch of kind of groups. And as you'd expect, there are some different answers by who answers the question. And so if you ask the surgeon, yeah, 9 times out of 10, we work great. 9 out of 10 surgeons say that. 2/3 of the nurses say, we work great. And then less than half the anesthesiologists say we work great. And so this is, the point of this slide is that context is really important, and perspective is really important. And as and some other hospitals in the different specialties might be different levels, but it's not always the same viewpoint from every different specialty. And we have to recognize that as we're working with all the different specialties together, and listening to everyone, and empowering and engaging everyone. This is really an important lesson, and because, and from this example, it works great, but some other groups might not think it works so great. And so that it's an important in communication and teamwork. I'm going to end here with this last slide, because this is really important, and this is also work that's come out of a sociologist in terms, and it's called the positivity ratio. And as we're trying to improve our culture and teamwork and communication, positivity is really important. And so when we first asked this, and this is you'll know the answer here, but when we first asked people, just without even giving them an option, like, how many positive things should you say to every negative thing? And most people think, oh, I should do, every positive thing every negative thing I should say a positive thing. Or every negative thing I should maybe say, 2 or 3 positive things, and that will make our team work better. Well, sociologists who have studied this over and over again have found this, is that if we do say one negative thing and 6 positive things, that will make our team more cohesive. But anything less than that might not work. So this is way more than anyone would ever guess without even, without having the option of knowing what the positivity ratio should be. And for people just starting out and trying to do positivity ratio of 6 to 1, 6 positive things for 1 negative thing, it's very hard. It's very hard to do. I mean, it's almost impossible. I mean, it's almost fake. Like, oh, I like your hair and your shirt and you brushed your teeth. I mean, like, I don't even know. It's not so easy. But it is very important. So let me see what the next slide is. Oh, okay, I'm going to end with this slide. This is the thing that we see that we have to fix. And maybe this is just in the States, but it's the word but. People will always say but. You say something, I think we can get the patient, we can call for the patient sooner. But, this thing happens, but this, but. And if you have a conversation and you're trying to move forward and you just count the number of times somebody says but, it'll astound you. And what people then get to is this, yes, but. Yes, that's a great idea, but we can't. Yes, that's very innovative thinking, but. And so we have to really temper ourselves when we hear these things. And a lot of folks have tried this strategy, the yes and strategy. So somebody says something, yes, and we could try to do this, and we could try to do this, especially for the brainstorming and innovation parts, when you're trying to think of a new way of doing things. These are techniques in terms of innovation, in terms of teamwork, in terms of ways to communicate. And so, try this when you're working and trying to innovate and trying to think of new ways to do things. It'll foster much better communication. It'll foster much better teamwork. So I'm going to end here. It's almost time. And if there are any questions, I'm happy to answer either this or later today. But thank you very much for your attention.
I hope there will be some questions because we have 10 minutes and I'm sure some of you are puzzling over some things because I've got one puzzle that I want Cliff to answer for me. He reinforced my impression that variation is the enemy of quality and we should strive for standardization for all the reasons that he's outlined. But then he introduced this term equifinality, which I hadn't heard before, and that sounded like there were more than one ways to skin a cat, so we could all do things the way we wanted to do. And I have trouble rationalizing those two. Can you help me with
Sure.
that process?
Yeah. So that's good. So the standardization aspect is very important for the reasons that I tried to say in the talk. Just get everything the same way. There's expectations that are people understand and whatnot. The aspect about equifinality, and I probably did not do it justice, is that before you standardize, when you're trying to look for the way to fix something, there could be a number of ways to fix it. You just have to identify that fix and then standardize. But so the example that I tried to give, not very well probably, is that the Mayo Clinic, what they found that they needed to do to fix their SSI rate, or what they did do and their SSI rate went down, is they started using a closing tray. So for their colon operations, before they closed the abdomen, all the instruments that they used for their operation, they got put to the side, and they opened up a whole new tray of clean, fresh instruments. They changed their gown, they changed their gloves, and then they closed with clean, fresh instruments. Their rates went from higher than expected to lower than expected within 3 months. The Cleveland Clinic, which is another very famous large clinic hospital in the U.S., they do 2,000 colon cases a year. They tried a closing tray, their rates were still high. They tried a different prep, their rates were still high. They tried a different scrub, rates still high. It wasn't until later on that they did something else with their antibiotics, because their antibiotics that they were using had resistances in a bug that was in Cleveland, in the Cleveland Clinic. So they were not using optimal antibiotics. So they had to try something else. So the equifinality piece is that there are a number of ways that are potential to fix something. But once you find that key thing, then you should standardize. So hopefully that's a little more clear.
That is more clear, but I have a follow-on question, and we'll come to Mike's question after that. So we should standardize, but the message which we put out from the Commission in terms of the tools that we use for quality and safety in the operating room, like the surgical safety checklist, is that here's a template, but you can use whatever form of it you like in Christchurch or Timaru or wherever. It does not have to be the same. So at what level is that standardization important? Is it important that we use the same tools throughout New Zealand? Or is it important only that we should use the same tool within a hospital? Or is it important only that we should use the same tool within an operating theatre? At what level is standardization important?
Yeah. Great. That's a great question, and there's a whole field of implementation research, of figuring out what's the best way to implement something, and I think of the choices that you gave. It should not be across the whole country, because if you visit one hospital and then you visit another hospital, it could be totally different, and it won't fit in both those hospitals the same. Then if it's between a hospital or a service within a hospital, I think a lot of that depends on the individuality of that hospital. If it does one type of surgery and most everyone is on board with that, then they could probably have one way of doing it. But if it's orthopedics and general surgery and vascular and cardiac, and it's so different and they need to have their individualized ways of doing things, then that makes sense to make it more individualized. What we need to do is to it's going to be that stepwise journey of saying, all right, well, I don't know if it's better to have one way of doing it for these 3 services or 3 different ways. But very clearly, if you choose one way and it's the wrong way, you will know that. And so that's when you should innovate, change it, get better, and then standardize. So a lot of times we don't know what the right answer is, but pick one and then pick with the right guess of the whole team's input what we think it is, but then figure out with data whether it's complaints or whether it's tomatoes thrown at you, what the happiness or unhappiness of it, and then change to what's going to work better.
Mike, down the back.
Is the method of data collection uniform amongst all those hospitals? I find with surgeons in my service that there's not a whole lot of trust that the data is accurate. It's really hard to get people to engage because they say, well, our data is not not collected correctly, and this is a data collection problem. This isn't a clinical problem.
Yeah, that's a great question, and it's a great point, because everywhere, if people don't believe the data, then you can't start doing anything after that. And so collecting data or having believable, meaningful data is going to be really important. The program that I showed with the 600 hospitals, what that program does is doesn't trust the surgeon to put in the data. There's a data collector who is trained and tested annually to be able and collects that data, and then that data are then audited on the back end once it comes in. So that program bends over backwards to make the data as standardized and as accurate and rigorously done as possible.
With regard to programs like ERAS, the implementation of such a program, have you got any strategies for dealing with either people, like a surgeon or a department who are quite resistant to taking up such a program?
Do they have a strategy? I'm sorry.
Or do you have any strategies that you would use to try and implement a program?
Yeah, I think that in terms of anything, just starting off small with a group who are believers in it or who are willing to try it is usually the best strategy. There's this great book. It sounds kind of hokey, but it's called The Power of Positive Deviance. And and it's not a hokey book. It's real. It's a legitimate book by scientists who go into and when they find a problem, and 95% of the population have this problem, and they find 5% that are positive deviants where they've figured out how to fix it. And what their idea is that they go to that 5%, learn it, and they try to scale it out to the other 95%. But what they learned is that they can't scale it out to the other 95% unless the other 95% are receptive. And so no matter what strategy they use, and it's working in this 5%, and so they tell the other 95%, it's gonna work, you're gonna get much better. And you know, like they deal with hunger, like starvation in Vietnam, or things like that are populational things. But if the other 95% are not receptive, then it's not gonna work, no matter how much data or things you throw at them. They only work with the faction of that 95% who are going to be the early adopters or the believers. And so I think that the same thing in hospitals, when we watch hospitals try to roll things out across the board, and starting off with something like ERAS, where it's going to take a huge effort from different disciplines, working with the people who are believers and who are going to put in that extra effort is probably the best way to get it implemented. And then it'll kind of expand once other people see the success.
Well, thanks, Cliff. I think we should move on.
Great.
Appreciate that.